Thank you. So today we have Dr. Lasley joining us, and she is the Radiation Therapy Program Director at NKU and a professor. And she's going to share with us just a little bit of information about radiation therapy and answer any questions you guys have, which you can put in the chat or you can unmute yourself at any time and ask. And then I did want to let you guys know that next week on the 28th, we have somebody coming to talk about internal medicine and pediatrics, and they're with the UK College of Medicine at NKU, and that'll be Dr. Landorf, and she does pediatrics. She's a pediatric physician.
So I did this years ago with a master's degree in my previous job. We did this for all the college pretty much regularly. So everybody knew about radiation therapy because we were a school, an undergraduate school that talked about interdisciplinary education and how all the healthcare professions work together to cure the patient. It's not just working in a silo. So I wanted to share this with you because it is really important that you know it's not just one, it's not a pediatric physician caring for the patient, but it's everybody. And sometimes we get caught up in working in our silos. So what is radiation therapy? Well, this is using high energy X-ray for the treatment of tumor cells while sparing healthy tissue. So this is a picture of a linear accelerator. Let's see, can you see my cursor? Where is that goober? Can you see my cursor now?
I'm not seeing it, no.
Okay, hang on.
Oh, now I see it.
Yep. He doesn't want to do much. Let's see. So this is the picture of the linear accelerator, and the actual X-ray beam comes out of the head of that gantry, and it's invisible. And it's much like radiography, except it's on a much higher level. We work in two forms of radiation treatments. One is external beam, and the other is something called brachytherapy. And I'll show you that in a second. Here's the actual picture of the external beam. We don't wear high-heeled shoes with a heel or looks like she's got some hose on with a skirt. We wear scrubs and we wear comfortable shoes because you're on your feet all day. This is actually a picture of how we use brachytherapy. So within each one of these, I'm trying to get my cursor over here so I can show you this. Doesn't want to move over there. There. Okay. Each one of this is for cancer of the prostate, for example. This is showing an AP picture of it. And for each one of these needles that are in this area, they're actually inside the prostate gland with radioactivity. And this picture on the left that you see is an X-ray taken from the side or the sagittal view. And you can see these dots right here. This is a rectal marker. So we put this in the patient so we can determine where the rectum is. And then you can see right here, this circle, this is contrast media that we put into the urinary bladder so we know and can determine how far and how much dose these two critical structures in the body can receive. So we calculate everything based off of that. And here's another example of the brachytherapy sources. These are actually gold seeds. Can you see the seeds? These are also in the prostate gland, and these don't come out of the patient. They stay in the patient because the half-life or the radioactivity energy is 2.7 days. So once 2.7 days is gone, the patient is no longer radioactive. And there's very little dose to family members during that 2.7 day time frame because the only thing the patient has to do is really they can't put little children on their lap for 2 days. But it's an easy, knock on wood when I say this, an easy surgery for the patients to have. And 9 times out of 10, this cures the prostate cancer without really damaging other structures in the area. Patients come in for a consultation, and then we do something called a simulation. We have to plan where we want to treat the patient. We can't guess. That's not our thing. Then we schedule the treatments. The patients see the radiation oncologist weekly to make sure that things are going fine. And they're scheduled for follow-up visits. And their first follow-up visit is usually every 3 months, 6 months, and then they get released to come back once a year just to see how everybody's doing. During the consultation, that's usually a very sensitive time, and we recommend that patients bring one family member with them, because sometimes it's better to have 2 ears listening than just one. You find yourself, when you go to the doctor's office for an illness, sometimes you don't really feel good and you may miss things that are being said to you. So usually that's the time that the doctor will talk about treatment options. And as you know, even if you're reading Ladies' Home Journal or whatever's out there for you to read or listen to the media news, you know that there's multiple treatment options available for our patients, especially for breast cancer patients. There's multiple treatment options from which patients can choose. Then we talk a little bit about the staging of the disease, and we base that off of the tumor size, and whether or not there are any nodes involved, and whether or not the possibility of metastasis is already there during that patient consultation. Here's a picture of an old-time simulator with a mannequin, and this is where the students would practice. Now, we don't have this at NKU, but it was something that has been used in the past, and quite frankly, I miss it. I'm just saying, but we do other things in the simulator, so I'll show you that here in a minute. This is a virtual environment radiation therapy unit, and I had this at my previous institution, so I'm working on contacting those people to write a grant to get this for my students, because what this does is we're able to make the skin go away, and then you can see the critical structures under the skin. We're able to highlight the beam so the students actually see where that area is that we're treating. It's really kind of cool. And we can do it in 3D. So they've got 3D glasses on here, and then the pendants are all the pendants the students would use during clinical rotations. And here's another picture of that virtual environment radiation therapy. It's really cool. We mark our patients because, as I said earlier, we can't guess where to treat. And so we do line that up with a laser beam that comes out of the side walls over here. And we have to do that to make sure our patients are in the exact same plane, that they're not crooked laying on the table. We have to adjust for that. The number one thing we work with as a therapist in the treatment room is getting our patients in the exact same position. And you have to think too, these patients don't want to lay on the hard table, because I make all the students get on the hard table, and it is very uncomfortable, and you guys are, happy and healthy. And some of our patients aren't all that comfortable laying on a hard table. So we have to take that into consideration too. We also make things called immobilization masks, and this starts out as a flat piece of mylar that we put in a hot water bath, and then we mold it over the patient's head. And the reason why we do this for patients diagnosed with head and neck cancer is, if we're treating any area in the head and neck area, we cannot treat the cervical spine. And so any movement from the patient would cause a risk in that area, and that's what we're trying to avoid. We also use immobilization devices. All the students learn how to use these vac bags. I don't know if everyone's familiar with something called a beanbag from the 60s and 70s, but we can actually, it's like a beanbag chair, and we can suck the air out of it and it molds to the patient. And the patients have always found that this type of immobilization device is like their own little bed, so to speak, and they know how to wiggle in it and get in the exact same position that we need them in every day for treatment. We typically treat 5 to 7 weeks, depending on what the dose prescription is. And that is up to us to deliver that dose according to the doctor's prescription. There are many treatments out now that we can treat 1 or 2 days, and the patient comes back for a follow-up, which is fantastic for the patient, kind of sad for us in a way, because we lose that patient contact. And that's one of the greatest experiences of the field, is we really get to know our patients. Sometimes our patients we treat for palliative purposes, which means we're trying to relieve a little bit of pain for the patient. We're not going to cure the patient, but we're relieving some pain. And this is with metastatic bone disease from another primary disease. So for example, breast cancer will metastasize to the bone. And when it gets to that stage, it becomes very painful for the patient, but we can relieve some of that pain by giving them 2 to 3 weeks of radiation therapy, external beam. And like I said earlier, we were able to offer 1 to 3 days of treatment for some of these newer pieces of equipment out there. And so the doc is always around. The doc is never not there, because he has to be there. That's part of a policy. The physicist always has to be around to make sure that we provide the best quality patient care. The curriculum, I know that was one of your questions, Avery. So the curriculum, there's a lot of radiation physics. And for some people that scares people away, but even if I'm covering a physics class for somebody, I use these inventive tools that made it work for me as a student, and I've kind of kept that in the back of my mind. So if we're talking about that invisible ray hitting the skin, there's different things that can occur. And so we practice a lot with, this may sound funny, pipe cleaners and little fur balls, and I make them glue things together, and we create models so they can actually visually see some of these abstract concepts that you can't visualize. Patient care, there's a patient care course. We look at everything through a cross-sectional anatomy. We have a little bit of pathology in our clinical oncology courses that we talk about, that has to do with understanding not only the stage of the tumor, but what made it that stage of the tumor. And we talk a lot about radiation health and safety. We're in that course right now, and the students are finishing that course up with me this semester. And of course, it goes without saying, we have to know the anatomy. And there's a lot of anatomy involved in it. So if you've already taken your A&P courses, please don't sell those books back, because they're going to help you someday. Clinical practicum, you will go to clinic, and you have 7 semesters of clinical experience, which is very valuable to your learning. And we let students know, for example, if you want to major in radiation therapy, we let students know you need to sell yourself. You need to show your interest and ask those quality questions that triggers in their mind, hey, this is somebody we may want to hire someday. You do get a credential after graduation. You'll become a registered technologist, and you'll have a T after your name. These are some helpful websites for radiation therapy if you're interested in that major. this organization, these are the folks that come up with the 220 question 3-hour national board exam that you take at the end before you start your job. This is our professional society right here, the ASRT, and you can go to any of these websites now at any time. And this is the Association for Oncologists, that the radiation oncology community has their own organization and standards that they follow. And I'm sure some of you, without asking, would like to know what dollars are involved as a radiation therapist. I do know in the Cincinnati area, you can make up to $70,000, $75,000 a year. In the past, I've had students go to other states, for example, state of Washington, state of California, and you got to take it into consideration. If they're making over $100,000 a year, their cost of living out there is going to be a bit more. So these are some of the things you have to think about. I think for Kentucky and Southern Ohio, the cost of living here is we can survive and not feel like all our money is going into rent or car payment or whatever we have to pay. So to be successful and to be, to graduate and make it through, well, come on. There we go. You do have to have a very special personality. Not everybody can work with a patient diagnosed with cancer. You really have to like talking with people. You need to make eye contact. You need to be sincere. You need to be a good listener. You need to be empathetic. That's probably, empathy is probably the number one thing we work on with our students in clinic. You need to be an encouragement, and you need to smile every day. That's just part of what we do. And students, it's interesting when I read their self-reflection writing from clinical, they said, but not everybody wants to talk about their cancer. I said, good night. Nobody wants to talk about their cancer. They want to talk about where they went to lunch, and they want to talk about the grandkids, and they want to talk about books they've read. And that's what you're there for, is you are there, basically their listener. And you have to be determined if you want to be a radiation therapist. It's like I said, it's not everybody's desire to do that. And you have to possess certain skills. And some of the skills that's really needed to become a radiation therapist, you have to be detailed oriented. You have to be able to understand what's going on inside the patient's body. It's not everything is on the outside, but it's what's going on inside with those cells that's really important. And you have to have a compassionate heart. This is good old Duke. Duke has since gone to doggy heaven, but he was a great pal. And you have to have a compassionate heart for this major. Question, how long does it take to get the degree? At NKU, it's 3 years. So if you come in with some transfer credit, that first year you would do your gen ed, and some of your transfer credit would come in. I'm just saying, or not, I don't know that. The advisors would look at that, but it's 3 years and you get a bachelor's degree.
I did have one question about what you kind of touched on it a little bit, but what is the most rewarding part of your job?
It is for me, and it will always be the patient. My patient has been like my best friend. And for me to create those relationships, I still have Christmas ornaments from years ago. And I know these patients are at a better place right now, but I won't get rid of the Christmas ornaments that they gave me after their treatment, because they become your best friend. You find out everything about their families. You listen to things that you didn't think you were capable of listening to, but they become your best friend. There are very few students that growing up, unless somebody's family member had cancer and they went with them for treatment, few people know about this major. But the job market is wide open. So you could easily get a job following those recommendations and trying to stay focused and wanting to care for patients that are really pretty sick.
So one thing we do like to ask some of our presenters is this something you always wanted to do, or did you have like a wonky path to get to where you are?
I had a wonky path to get to where I am. I started out in radiography and I loved it. And I worked 3 to 11:30 shift at a downtown hospital in Akron, Ohio. And we were all about the same age and we all went out after work and we just had the blast. I covered the emergency room and it was wonderful. And then during my before I actually worked as a radiographer, during my rotations, because we had to visit all these other areas as part of a program that I went through in 1975. So don't say anything, Avery, but that's been a while ago. And I went to shadow radiation therapy and I loved it. And I thought, well, if there's a program nearby and I can apply and try and get into that. It's not that I didn't like radiography, because I liked that too. So I'm certified in both fields, radiography and radiation therapy. So having multiple credentials allows me to, kind of spread my wings and work in multiple institutions. So for example, radiography in an NKU, not with some prep, I could cover some of their classes.
Mm-hmm.
But it was kind of wonky how I got in there.
Yeah, we like that because a lot of people think you have to have it all figured out ahead of time.
No. No, in fact, getting the bachelor's, I think I was working as a therapist at St. Jude in Memphis. Mm-hmm. And I didn't have my bachelor's at that time. And in Memphis, they had Baptist College of Health Sciences, which I ended up working at after I graduated with my bachelor's. And then from there, I went and got a master's in healthcare administration. And then from there, I always knew in the back of my mind, back here, that someday I would get a doctorate. And I really wanted to do that, and I wanted to do research. So a lot of my students were involved in service learning. So one semester, one of my courses when they're senior years, we go out to the Brighton Center and we tell everybody about our profession. So I measure professionalism. And the students love it.
Yeah. Oh, we got one more question in there.
What type of bachelor degrees transfer towards radiation therapy? Well, I'm not the content expert, but I can tell you what, if you're a really any kind of bachelor's degree will transfer credit for like English 1 and 2, college writing, calculus, pre-calculus. If you've already taken those courses in whatever bachelor's program you have, knock on wood, that should transfer in. So if you were a biology major, or if you were already in the health professions, I would say it would be a bit easier transfer. I don't know if that answered Mary's question. Anthony, okay. Was there anything that really surprised you in this job? Yes. The one thing that really surprised me in the job is I didn't think I would get that connected to my patients. I mean, I was never depressed or sad, I looked forward to coming to work every day. Mm-hmm. And when for example, here's a great one. Not that Anthony would experience this. I was on maternity leave, and who was covering my patients on my machine? I worried while I was on maternity leave whether or not they would remember to ask, how was lunch yesterday with a certain patient, or whether or not they put like a folded pillowcase under a patient's elbow because the table was kind of jabbing them. I mean, those things I worried about, and that surprised me about myself, that I would continue to worry so to speak. But now I worry about the students. Have to like a little bit of math and anatomy, physics, because it's just that's common. Those are common courses across many of our disciplines in healthcare.
All right. Well, thank you so much. Avery, you can go ahead and start taking it away.